Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristen Jackson. Every week, I share my over 25 years experience to guide both men and women as they age. Listen as I discuss a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. It's happening to all of us, so listen for some solid scientific knowledge on how to handle these changes. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Today we're talking about menopause and mood disorders. This is how hormone fluctuations affect our brain and all of the mood changes that can occur because of it. We know that menopause is characterized by a decline in estrogen and progesterone levels. And these hormones, the loss of these hormones, can have profound effects on neurotransmitters in our brain. Estrogen in particular plays a key role in regulating our mood. And its decline during menopause very often contributes to the development of certain mood conditions or the exacerbation of them. What is the prevalence of mood disorders in women in this age group? Well, research has suggested that women are more vulnerable to mood disorders, things like depression and anxiety, during the menopause transition. And studies have shown that the rates of depression tend to increase as women approach menopause and then remain elevated through the rest of the postmenopausal period. We know that the symptoms of mood disorders during menopause can vary widely. Women can experience sadness, irritability, anxiety, like every little thing gets on your nerves, mood swings, and changes in your sleep and appetite patterns. And it sounds like these are just natural emotional changes, but these are persistent and severe things that can significantly impact your daily functioning. There's a lot of information on what are the biologic mechanisms that explain the link between menopause and mood disorders. And as you may have heard me say before, hormones like estrogen and progesterone don't just work by floating in our bloodstream. They've got to attach to a receptor and create a change in a cell. Well, our brain has tons of receptors for both estrogen and progesterone. So let's look at how the loss of these hormones affects the estrogen and progesterone receptors that already exist in the brain. Estrogen plays an important role in modulating lots of our neurotransmitters in the brain, including things like serotonin, dopamine, norepinephrine, and the GABA system. Serotonin, we often refer to as the happy neurotransmitter, the feel-good one. It's involved in regulating mood, and estrogen regulates serotonin levels by making sure that we create more serotonin, release more serotonin, and we don't get rid of it. We don't have reuptake of our serotonin too quickly. The other brain neurotransmitters, dopamine and norepinephrine, are involved in the regulation of things like motivation, pleasure, and attention. So estrogen also increases the availability and function of both dopamine and norepinephrine. So we're going to have improved results in those functions of motivation, pleasure, and attention. The third neurotransmitter, GABA, is the primary inhibitory neurotransmitter in the brain. GABA actually reduces nerve excitability and promotes relaxation of nerves. Estrogen influences GABA receptors and makes us have more GABA receptors, so we have more neural relaxation. That leads to decreased anxiety and a decreased stress response. So we can see that estrogen in particular is specifically functioning on all of the key neurotransmitter systems in the brain. A second way estrogen affects our brain is by its effect on the HPA axis. That stands for the hypothalamic pituitary adrenal axis. This is a hormone cascade that starts in the hypothalamus in our brain. Certain hormones travel to the pituitary in our brain, and then different hormones travel to our adrenal gland. This is a key axis for modulating our stress hormone because it's our adrenal gland that produces cortisol, which is our primary stress hormone. When this axis becomes dysregulated, we get exaggerated cortisol response to stressors. So, things that normally would be a stressor in our life that might just release a small amount of cortisol, all of a sudden they're releasing an incorrectly large amount of cortisol. And this has been observed in menopausal women experiencing mood disorders like depression and anxiety. And the thought is that estrogen withdrawal during menopause really disrupts this very delicate balance of the HPA axis. So it allows the HPA axis to function in a hyperactive state and have this exaggerated response to stress. And this may explain why many women going through menopause say, every little thing gets on my nerves. Things that used to not bother me are suddenly just causing me this insane amount of anxiety and stress. It's because of this exaggerated response of the HPA axis. A third way estrogen affects the brain is in things called neuroplasticity or neurogenesis. Neuroplasticity and neurogenesis are the processes by which the brain forms new connections between nerves. And we need to form new connections when we are learning and creating memories and regulating our emotions. When we have estrogen depletion during menopause, these processes of growing new neurons and learning and remembering become impaired. And that's another major complaint of women during the menopause transition are these cognitive difficulties. Sometimes they're lumped all together and called brain fog. And it just means that you can't keep everything in your mind as quickly and easily as you once could. So, reduced levels of estrogen during menopause are associated with decreased synaptic density. That's literally how many nerves we have firing at one time. And decreased neurogenesis, that's the growth of new nerves as we create new memories and create new learning environments. So, when all of those things are decreased, you can imagine that all the symptoms that we experience are this kind of brain fog symptom where memory is impaired, learning is impaired, and thinking is impaired. Finally, we have neuroinflammation or oxidative stress. I often talk about estrogen as a very powerful anti inflammatory hormone. So, estrogen in the brain protects against inflammation around our nerves and oxidative stress around the nerves. Both of those processes have been implicated in causing mood disorders. So, once again, estrogen depletion during menopause leads to increased neuroinflammatory responses and increased oxidative damage to the nerves in our brain. And this can actually lead to the development or even the worsening of pre-existing psychiatric symptoms. Since estrogen has that antioxidant and anti inflammatory effect, it helps to keep the nerves in our brain from experiencing oxidative stress and worsening any cognitive symptoms. So that's a ton of research, biologic research actually showing how the estrogen molecule protects and keeps our brain healthy. But there are other things happening as women go through the menopause change that might lead to mood disorders. There are psychosocial factors, life stressors happening at this time in their lives. Women in their late 40s to mid 50s might be having children growing up and leaving the house. They might be having relationship changes. They're dealing with society's attitude towards the aging woman and what they can contribute to society. All of those psychosocial factors play their own role in creating mood disorders during menopause. There are also certain factors that put a woman at higher risk for experiencing mood disorders as they go through menopause. That would be a history of depression or anxiety. If they already have a baseline of depression or anxiety that they're treating, it's likely that it may worsen as they go through menopause. The presence of other menopausal symptoms like hot flashes and sleep disturbances have also been associated with a higher chance of mood disorders. So, treating hot flashes and sleep disturbances is not only to make you feel better, it's actually to reduce your risk of having things like anxiety and depression as you go through this transition. Women who have lack of social support during this time or are experiencing those stressful life events that I talked about before can also be at higher risk for experiencing mood disorders. And changes in the brain during menopause are not only limited to these mood changes. There are also concerns about increased risk of dementia in both men and women as we age. But let's look at the association of dementia with waning hormones that happen during menopause. There's definitely been research to see if the addition of hormone replacement therapy can reduce a woman's risk of developing dementia as she ages. In a great prospective study in 2002, they followed 1,300 men and 1,800 women, average age in their 70s. And they found that about 2.6% of the men and 4.7% of the women developed dementia. So, first, just recognize that it's twice more likely to develop dementia in women as it is to men. And the risk for dementia in women increased after age 80. And that was even higher than men of similar age. Women in the study group, though, who used hormone replacement therapy had a reduced risk of dementia. And in fact, their risk of dementia disappeared completely if they had been using hormone replacement therapy for 10 plus years. So this is starting to show that there could be a benefit for hormone replacement therapy at reducing a woman's risk of dementia, but it might be related to when she starts the hormones and how long she uses them. We know definitely that sex hormones are potent regulators of the nerves, like I've talked about before. And Alzheimer's disease is an age-related neurodegenerative disease where several things are happening in the brain, but a lot of the processes are due to depositing these beta amyloid plaques in the brain, as well as increased inflammation and loss of neurons or nerves in the brain. So, those are two of the main mechanisms by which a patient develops that type of dementia. We know that serum estrogen levels are lower in women who have this type of dementia. So, you might make the hypothesis, well, if serum estrogen levels are lower, then when we replace estrogen, we should prevent dementia. But so far, the studies have been a little bit conflicting on this. There are tons of studies supporting the use of estrogen in preventing dementia. Many studies show that the risk of dementia is lower in current hormone users. And a meta-analysis, that's a study that looks at the results of multiple studies together. A meta-analysis has shown that hormone replacement therapy is associated with a decreased risk of cognitive function. So that seems to support the hypothesis. But then there are some studies showing that hormone therapy is not associated with a reduced risk of dementia. What we need to understand, though, is that in a lot of those studies, the timeline over which they viewed the patients might have been too short. The risk of dementia does not decrease with just a short term, several months, or even a few years of hormone use. The study needs to be long enough to actually see a benefit, so it needs to be over many, many years. We also know that a nerve's ability to respond to hormones decreases with age, meaning when hormone therapy is started earlier, when the nerves are still healthy and responsive to estrogen, you can get a big decrease in the risk of dementia. But if hormone therapy is started later in life, when the nerves are less sensitive to estrogen, you're going to add that estrogen and not see the decreased risk of dementia. So we definitely need more study in this area and more properly designed studies so that we actually can try to see an effect if one is there. What we do know estrogen can do is from biologic studies. So we've really looked at how it works on neurons in the culture dish and neurons in lots of animal brains. We know that estrogen definitely protects cultured neurons from those beta amyloid plaque development and toxicity. It also decreases cell death. That's called apoptosis. And that's another feature of dementia where the neurons are just dying, and estrogen does inhibit that neuronal apoptosis. I've mentioned before that estrogen is anti-inflammatory and it protects nerves against oxidative stress. But once again, studies show that estrogen is only protective to the nerves if it's given before the oxidative stress happens. If you create oxidative stress in a nerve and then give the nerve estrogen, the estrogen doesn't seem to do as well. So this is more data to support the fact that early estrogen use is the most effective for protecting brain cells rather than later estrogen use. In both guinea pigs and rats, there are studies showing that estrogen replacement decreases the beta amyloid plaques in the brain. They can actually reverse the amyloid plaques in the brain. So that's certainly an encouraging finding. But they also show that the aging brain loses its responsiveness to hormones after the brain has been in an extended period of time without hormones. So they did a really neat study in rats where they removed the rats' ovaries, so basically depriving them of estrogen. And then in some of the rats, they gave them the estrogen back right away. And in other rats, they waited many months and gave them the estrogen back later. What they found is that the rats that received the estrogen right away after the ovaries were removed showed no increase in beta amyloid plaques in their brain. Whereas in the rats where they waited many months to give the estrogen and then gave the estrogen, those rats did show a huge accumulation of beta amyloid plaques. Again, supporting this theory of the critical window. When's the safest time to begin your estrogen? Early is always better. And why is it that the aging brain does not respond to estrogen as well as the younger brain? Well, there are lots of theories on that as well. And it probably has to do with a decreased expression of the estrogen receptor. Remember, the estrogen can't do anything floating around in our bloodstream. It's got to attach to its receptor and cause an effect in the cell. So as we age, the number of estrogen receptors that we have in our brain just tends to go down. So estrogen is not going to have as good an effect. Also, the estrogen molecule itself has to properly bind to the receptor. It's like a key in a lock mechanism. The molecules have to match up perfectly and click, and then the estrogen can cause its effect in the cell. And again, as we get older, the estrogen molecule doesn't bind to the estrogen receptor as effectively as it once did. So it really is important to flood that brain with estrogen when there are already lots of receptors there. That's the younger brain. And when the estrogen can effectively attach to the receptor, again, that is in the younger brain. So let's bring this all around and say, if patients are experiencing mood disorders as they go through menopause, what are the treatment options? Traditionally, mood disorders have been treated with antidepressant medications. You might hear these called SSRIs or SNRIs. SSRIs are selective serotonin reuptake inhibitors. That means they work in the brain by preventing the uptake of serotonin, meaning there's more serotonin around in the first place. It stays in our brain longer. And we said that serotonin is the happy hormone, the positive mood hormone. So, of course, that's going to have a positive mood effect. But SSRIs can have a long list of side effects. Some of them are a little bit annoying, like GI upset, headaches. Some of them are going to mimic the changes of menopause anyway, like sleep disturbance, weight gain, sexual dysfunction. Well, women going through menopause are already having these types of changes, and the SSRIs, while maybe making their mood disorder better, are going to impact their sleep, their weight, and their sexual dysfunction in a negative way. So they're going to make one symptom better, but maybe many other symptoms potentially worse. Plus, we also need to be cautious about serious side effects of SSRIs, like suicidal thoughts or suicidal behavior, high blood pressure, arrhythmias, especially with overdose. So they need to be monitored very carefully. In my opinion, SSRIs are not working at really why the mood disorder is occurring during menopause. We've talked so much about the mood changes during menopause being due to the lack of estrogen or the loss of all the protective effects of estrogen in the brain. So using hormone replacement therapy seems to make much more sense. You are replacing what should have been there in the first place. And not only are you protecting the brain against all of the mood changes and all of the inflammation in the brain, you're treating a whole host of symptoms that are occurring in the entire body due to that lack of estrogen, not just in the brain. So you're getting much more bang for your buck by treating with that. Of course, it's always a good idea to consider lifestyle modifications like exercise, stress management, acupuncture, and yoga may have a role. We talked about the abnormal stress response of the HPA axis. So anything that we can do to minimize that abnormal stress response is important. So listening to music, walking in nature, meditating, exercise, all of these things have been shown to decrease the abnormal cortisol response. So those things can help with the hyperactive HPA axis. Most importantly, treating women going through menopause, we really need to take an individualized approach. There's such a complex interplay between the biology of what's happening in the brain, what's happening with the women's psyche, what's happening in their social life, as well as their physical symptoms of menopause. We need to look at all of these things as a whole and try to treat the woman as a whole rather than slicing out each symptom and trying to attach a med to each symptom. And of course, as I always say, we absolutely need ongoing research to continue to look at the effects of hormone replacement therapy in the brain And as I said, those studies have to be well designed because it's not an effect we're going to see just over a few months or even over a few years. These have to be long-term studies where we can start studying younger women just going through the menopause and follow them not only through their menopausal change, but beyond into their later years to really see if we can make a positive effect on things like mood disorders and depression, anxiety, and dementia later in life.
Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.